All right, so I'm going to cover some of the big topics of week 2, just to give you a little bit of content overview, some of my little thoughts and some different ideas in there. So the first thing that kind of comes up is upper GI vomiting. Lots of people come through the ER with nausea, vomiting, so you got to figure out why, right? Is it an obstruction that's causing everything to back up and they throw up? Are they ETOH? Not just like drunk right away, but could be like long-term ETOH cirrhosis, which we'll talk about later in another week. Could it be a GI bleed that's up irritating their stomach? Is it pregnancy? There's so many different reasons why somebody could be vomiting. So figuring out the reason, and one thing I encourage you to do is to really look at your meds and know your meds. Some big ones that we give, Zofran, Reglan, Compazine, things like that. Know your meds. Also know your labs. If they have massive amounts of vomiting, you're going to see a change in labs. What is it going to do to their hematocrit? What is it going to do to their potassium? What is different things? So you could definitely tell a patient that's got chronic vomiting versus somebody that's been vomiting for an hour. So you can really see the difference by their labs. When a patient starts to resolve from vomiting, how do we get them to start eating again? So the big thing when getting people to start eating again is go slow. Right? I still remember the day that we put a patient on full liquids. He was like, sweet. And I gave him some examples and he went and ate salsa. Nothing with it, just straight salsa. Nothing like throwing up salsa because he went through this whole process again of us having to go back to NPO, right? So teaching our patients, go slow, but what to go slow with. A lot of people start out on clear liquids, go to full liquids, and then to maybe even a low fat where it's not as irritating, and then maybe to a regular diet. There's also GI soft, which is doesn't have any sharp things like chips, things like that. So you can really adjust their diets. One of my nurse pet peeves, no red Jell-O, none of that. We had a patient one time, I was a charge nurse, and he ate a bunch of red Jell-O. He was supposed to go home and he started throwing up again. Red. So we had to test, was it blood or was it Jell-O, right? So make sure, especially with GI bleed, no red, which is funny because almost every hospital has red Jell-O. Don't know what that's about. Another section that it's talked about is GERD, right? A lot of patients come in with GERD. This is due to an incomplete or incompetent LES, lower esophageal sphincter. A lot of people think that's the lower stomach. It's actually the top of the stomach, right? A lower esophageal sphincter, right? So it's not closing all the way. So acid is building up and backing up in through the esophagus and cause them to have vomiting, heartburn, lots of different kind of symptoms that can go with it. So what foods are causing this? So this is a big thing when you're looking at avoiding triggers. Highly recommend you look at that section. Sitting up after eating, my guilty pleasure, the 2 a.m. Pop-Tarts should probably not happen, right? So what is going to help that sphincter for that acid to not back up? One of the big things that can happen, though, that is kind of a complication is the acid backs up, and instead of them throwing up or something, it goes down the trachea and into the lungs. It can cause chronic asthma, chronic bronchitis, a bunch of different issues. So things we want to prevent. Another little side that I like to add is one of the signs of a heart attack or an MI can be heartburn, right? So they'll be like, man, I'm having chest pain, and it might be burning pain, but they can't tell the difference. So a lot of times we got to work people up for that chest pain, but it could just be acid reflux. What's the higher acuity? The chest pain, the MI. So we're going to work up the MI, and then we'll kind of backtrack to the heartburn. Okay. So that has a lot to do with GERD. The other piece that is in the upper GI, that's a big piece that I highly recommend you also read through, peptic ulcer disease, right? This is a erosion of the GI mucosa resulting from digestive action of hydrochloric acid and pepsin, aka the stomach acid is literally burning through the lining of the stomach or the GI tract, right? So this can cause different ulcers, so painful ulcers, especially when eating. We see this a lot with patients that take lots of NSAIDs and aspirin. Okay, one of the patients that take a lot of aspirin, MI patients, right? They take baby aspirin a lot of times post stents. That can cause peptic ulcer disease. The other one is NSAIDs. I've seen a lot of younger specifically males, but I've seen some females that are athletic, that take a lot of ibuprofen due to being sore or different things. Those NSAIDs can cause peptic ulcer disease. So the three big complications that they talk through is hemorrhage, right? Perforation, gastric outlet obstruction. Hemorrhage is big, right? Bleeding. We don't like bleeding. But the big one that is scarier to me in the long term is perforation. So what happens is the stomach contents literally burn through those ulcers and get into that peritoneal cavity. That is where you can get what's called peritonitis or hot belly, which I'll talk about later in this little section. So know those. What are you going to do? What causes them? Really look at those areas because those are big, especially in nursing action, like being out in the field. Okay. Then it goes through the lower GI piece. Constipation, always a concern in the hospital, right? These patients come in sometimes with constipation, right? A lot of people I see with constipation are usually either post-op. We have a big spinal surgeon here, and his patients have so many constipation issues, it's not even funny. The other one we have is we do a lot of like heart stents, specifically open hearts. Those patients also have constipation issues, right? You have decreased activity and opioids, right? And they're just not eating and drinking as much as they used to. But this also happens in the hospital, right? Either a surgery patient, any patient, they don't feel good, so they have the decreased activity. They're possibly on opioids, right? Or other medications that cause constipation, and they have decreased fluid intake. Yes, IV fluids help. Oral fluids, much better, right? So what do we do for these patients? Bowel regimens, right? Those bowel meds are huge. So get them up, get them walking if possible. We try to cut down on opioids and we try to have them push that fluid intake, right? So all three of those are going to help. The bowel regimen, bowel meds, huge. Start early, right? We don't want to get behind the 8 ball on that. Another section that I really like that it talks about is abdominal trauma. The first thing when I hear abdominal trauma in my areas, I think MVA, motor vehicle accidents, right? Some kind of trauma that hit the belly, but you can have it in different other ways. A construction site accident, a stabbing, things like that. The one we really think of is, you have that pressure or that puncture and you think belly bleed, right? And a lot of times belly bleeds are obvious. Hot belly, painful, red, things like that are the kind of the cues. But sometimes bleeds are not so obvious. I say this because I ran this simulation with my ICU nurses quite a few years, 2 or 3 years ago. 16-year-old car accident with this massive seatbelt chest bruise, right? And everybody was like, oh, I'm going to check out the lungs. Let's check out this. Oh, their belly's fine. So I'm not worried about that. And they keep going through this and they keep checking this patient. And the patient keeps complaining of pain. They can't tell them where. And their blood pressure keeps dropping, right? Because their blood pressure is dropping. There's not enough blood to push through. And their heart rate increases because it's like, hey, I need to get the blood to this area, right? And what they don't know is if they had looked at the back of the patient, they would see gray Turner sign, which is a sign of a retroperitoneal bleed or a bleed in the back. Okay. Those can be dangerous because they're not seen until it's too late. So assessing your full patient. Yes, I'm worried about their chest. I'm worried about this. Their neck's in a brace, so I don't want to turn them over. So many fears like that. You can still log roll these patients. You need to look at their back. Okay. Especially if you see those lower blood pressure signs. So looking for colons, which is the bruising in the belly, and the gray Turner sign. Okay. I will tell you 97% of the ICU nurses that ran that simulation missed it because they were so worried about other areas. Don't forget about those retroperitoneal bleeds. Okay. The other one that terrifies me, peritonitis, also known as hot belly. Okay. It's literally called hot belly because the belly looks hot, red, tender, things like that. It can be after abdominal surgeries, can be after a bunch of different things. So I always think of abdominal surgeries, especially like things like a ruptured appendicitis. Okay. You think of a ruptured appendix and then things are spilling out into that peritoneal cavity, causing different kinds of infection. That's why we see lots of IV antibiotics with those kind of perforations. We talked about earlier, PUD, things like that. You definitely want to, prevent peritonitis, B, assess for it, right? In kind of abdominal surgery, you're looking for signs of sepsis, okay? High temperature, high heart rate, high respiratory rate, and one of the last to drop, low blood pressure. Okay, so you want to watch for those things. Treatment, NG tube, IV fluids, and a ton of IV antibiotics. Okay, these patients take a long time. We've seen patients in our ICU for 2 to 3 months sometimes with those peritonitis, because it is such a big area, hard area to contain infection. And so we just don't like hot bellies. Okay. The last section it talks about, which I really enjoy the PowerPoint in the book, because I know a lot of people with Crohn's and ulcerative colitis. I take care of patients, and still there was some aha moments in this one because I really enjoyed looking through this. So a reminder, ulcerative colitis is just the lower intestine, right? What does the lower intestine really do? It absorbs water, bulks up stool. Crohn's involves the small intestine. So if you think of small intestine, you think of what its patho does is it specifically absorbs the nutrients, right? So if we are not absorbing the nutrients, we're seeing high levels of weight loss, right? Higher than ulcerative colitis. You can also see strictures. So there's so much inflammation in that GI tract that it starts to stricture, right? When it strictures, it can cause little abscesses to come off, which causes infections, which if those rupture, causes peritonitis. Okay, you see where I'm going? Like the Crohn's is definitely harder to control. We see lots of Crohn's flare-ups in our hospital where we have to decrease that inflammation and think nutrition for those patients, right? Not just oral nutrition, because if it's not really absorbing, we might have to do some kind of different nutrition for them. Okay. So that's my spiel on upper and GI. There's a lot of information in there. There's some good information that you will use in the hospital, right? Or whatever setting you go into. Upper GI and lower GI are big. So I hope you have a great week too. Don't stress too much. You got this. You can do this. And I'm praying for you. Have a great week too. Bye.